guys. So this is my medicine 1 oral case presentation. And I'll just go through it, like I'll analyze it kind of. And then if you guys want like a shorter version where I just present it, I can do that as well. But I thought it would be more useful for me to explain why I put everything in the slides so that you can do the same for your case, even if it's not shortness of breath, for example. Okay, so obviously you have to put in the no conflict of interest, and it has to be like um, two slides of substance. So like these 2 slides are the ones with the title slide doesn't matter, okay? So here it's best to like put the chief complaint, or if there's no chief complaint or it's like a bit complicated, you can just write the diagnosis. That's also okay. Okay. So start with chief complaint, the age, nationality, gender, and then shortness of breath, or like the chief complaint for how long. That's it. Like this is the chief complaint. You write the main symptom and for how long. And so when you're presenting, you say this is a, let's say this is a 40-year-old Mexican pleasant male or pleasant gentleman, okay? So when you're presenting it, be like a bit nicer, I guess, like, okay? And then you have to put in the HC, which I got rid of for this video. Okay, so the patient had shortness of breath. Now you have to analyze this shortness of breath, okay? So like using the Socrates or whatever, okay? So for how long? A week ago, gradual, gradual, and then worsened on exertion, like what makes it worse, what makes it better, severity, and then you end like that analysis, you end it with the associated symptoms. So it was associated with fever. You would ideally analyze this fever, like for okay. So we know for, I wrote over here for the same duration, but for how long? Is it high grade, low grade? Did the patient measure it? Is it the kind of fever that comes every few days? Is the fever more in the morning, in the night? Like, basically analyze the fever, okay? And then like, does it go on and off? Like, does the fever come and go, or is it just a constant fever? Did they take any medication for the fever? Things like that, okay? And then the cough. So here, ideally, you would just write associated with fever and cough for the same duration. And then you analyze the cough. The cough is productive with yellow sputum and occasional streaks of blood. And then it's also associated with chest pain that only comes with the coughing. So it's like, so you basically you say that the coughing leads to chest pain. So it's like pleuritic. No, like not pleuritic. Just it comes with the cough. Okay. And then you have to write the pertinent negatives. So no chills, no orthopnea. Orthopnea, like it's like it's a sign of heart failure. No sore throat, runny nose. These are like URTI symptoms, upper respiratory tract infection symptoms. Night sweats, weight loss. This could be TB. It could be a malignancy. So these are important like red flags to ask about. And then review of symptoms. So obviously you write down all of this, but when you're presenting, you say a review of system was unremarkable except for fatigue. So only the positive findings, okay? And then you can bold this as well. So the only the positive findings, you put them in bold, and only those you mention. If it's unremarkable, obviously you write all of this out, but you say review of systems was unremarkable, okay? And then medical history. So you have to write what conditions they have and since when they've had it. So COPD was diagnosed 3 years ago. Uncontrolled diabetes mellitus type 2. So when you say anything is uncontrolled, you have to prove it then in the labs afterwards. Okay, we'll talk about, we'll mention that again in a bit. So, and then no childhood illnesses. Okay, surgical history, he recently had an axillary abscess that was drained, or like that was excised. Okay, and he was given amoxicillin clavulanate for this axillary abscess excision. Okay, and then other medications, salbutamol, ipratropium, blah blah blah. This is for his COPD. Um, this is for his diabetes. No allergies, fully vaccinated. This could be important, especially in like peds and things like that. Um, okay, and then make sure that you know the mechanism of action of all the medications that you include in your presentation. Family history, no chronic diseases, no TB. TB is not family history, but still, خلاص, whatever. No asthma, no history of cancer, or no history of malignancy. Okay. Social history, he's a current smoker, 30 pack year. So you have to mention how much does he smoke. No alcohol, fiberglass worker, and like occupation can kind of, um, you know, like move you to like a specific any thing, okay, or direction. Unmarried, not sexually active, no recent travel, lives with 4 roommates, no sick contacts. So this is important in his case, okay? And then you go on to physical exam. So in physical exam, you start with, it's kind of like just following the checklist. So he looked cachectic, fatigued, dehydrated, no diaphoresis. Um, okay, vitals. Yeah, so you mentioned the vitals basically. He didn't have, he was afebrile, but his respiratory rate was 22. His SpO2 was 93%. And then you go through all the physical exams. So no clubbing, no peripheral cyanosis, no nicotine stain. So these are the things that you would find in someone who smokes. Um, oh, he did have nicotine stains actually. Um, okay, so no clubbing, no this, no facial swelling, conjunctival pallor he had. Okay, no central cyanosis, no tracheal deviation, blah blah blah. And then the chest. So because this is like respiratory, you have to analyze that specific system. Okay, so on inspection, normal symmetry, normal shape, no scars. Palpation, he had reduced chest expansion, increased tactile firmness, blah blah blah. um, Bilateral dullness over lower zone, over both lower lung zones. Auscultation, he had bronchial breath sounds in the right lower uh, lung zone. Okay, bilateral basal inspiratic coarse crackles, so he had crackles as well. Variable with cough and diffuse expiratory wheezing, increased blah blah blah. Okay, so this stuff, like, yes, it's important, but if you don't mention it or if you did not see it in your patient, it's not that big of a deal. Like this egophony and blah blah blah, like it's not that important. um but yeah, like just to show them that you did analyze the specific system that you're interested in. Okay, abdomen, blah 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 blah. And then just go over like quickly the other systems. Okay, like CVS, for example, he came with chest pain and he's a smoker and he's an oldish man. Okay, he's like in his 50s. Okay, um so that's why like you always have to rule out any um like MI or anything cardiac that could be happening, especially because he has shortness of breath. Any, it's good, it's important to rule out. Okay, lower limbs, blah blah blah, neurological, okay, unremarkable. Now, um, then you go on to diagnosis. So differential diagnosis comes after the history and the physical exam, okay, not after the labs. So this is probably a COPD exacerbation. It could be infectious or it could be non-infectious. Most likely in the infectious, this could be bacterial. It could be like community acquired pneumonia, um, uh, and then it could be viral. This could be TB because he does work in. I mean, he lives in like a very crowded kind of environment, and it could be fungal because he has uncontrolled diabetes here, and so and like long standing. But that's why, like, we should rule it out. Um, it could be non infectious, it could just be because this patient is not taking his medications regularly, and so that's why he got the COPD exacerbation, and then also because he's a fiberglass worker, we, this could be pneumoconiosis, um, which is like seen with these kinds of workers and stuff like that. Okay, so what labs did we do for him? And we did a lot of labs, but his white blood cells are 25, which is pretty high. ANC was 23, CRP was 221. His HbA1c was 11%. I feel like this should have been at the bottom, but um, because he had uncontrolled, because I mentioned uncontrolled, uh, it's like important for me to prove it later on, okay? Even if it's not, I mean, it's still important in his diagnosis. Then total IgE was super, super high for this patient, which was interesting. And then normal electrolyte levels, normal creatinine, blah, blah, blah. His urea was 10, okay? Now, this urea thing is important in order to calculate CURB 65 for this patient, okay? I didn't do it, but like for you guys, whatever diagnosis or whatever topic you're doing, make sure to include any score that is like popular or is like normally is like widely used. So like in pneumonia, for example, they always do CURB 65 or like those other like newer ones, okay? So whichever, just choose one and like at least show that you calculated it in your presentation. I didn't do that and I should have, but خلاص الله يهديني. Okay. Microbial testing. So we found that there was positive for Aspergillus flavus and fumigatus, E. coli positive, Staph aureus was negative, acid fast, like TB was negative, HIV was negative, ovoparasite, blah 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 was negative. Okay, and then we found, oh yeah, so here the antigen is positive, and this is like the level. And then we saw in the chest x-ray that there's like a consolidation over here, as you can see. So basically you would describe this x-ray. So you start with the adequacy. So is this x-ray adequate? First of all, is it APPA? We have to look at the patient's name and the date and the HC, and we have to confirm that this is actually the patient. And then we have to check, is the rotation of the like x-ray good? Is the exposure good? All of that, okay? And then you say, basically you go like you say, okay, trachea, any A B C D E, trachea or airway, trachea is not deviated. Yani this is normal, okay? This amount of deviation is normal. And then breathing, so you look at the lungs, say any, it's all mostly clear except for a consolidation in the right lower lung zone. And then cardiac, so you say the heart size is good, and we can see over here the notch, and we can see the right atrium and stuff like that. Okay, blah blah blah. خلاص, it's the right size. And then the diaphragm, we can see the costophrenic angles, and maybe it's a little bit blunted over here, I'm not sure. And then other things like check for fractures, check for anything else. Okay, so yeah, consolidation. Okay, and then they also did a high resolution chest CT, and that showed ground glass halos. And I honestly, I could not interpret the CT at all. And so I said, there's no point in putting the picture if I don't have anything to explain in it. I just got the result and I was like, خلاص, this is enough. Yani, this is what I'm going to say. Because this is not our level or our specialty to be able to interpret CTs and be able to see the ground glass halos or whatever, okay? And then you end with just like a summary of your patient, okay? So, something-year-old, whatever, Mexican man with COPD and uncontrolled type 2 diabetes mellitus presented with shortness of breath, productive cough, was diagnosed with invasive pulmonary aspergillosis. And what was the management for this patient? You have to, it is not done that well, but you have to split initial management from management after diagnosis. So you have to say initial management is to stabilize the patient. This is like the most important thing. You have to stabilize the patient. You have to check their vitals. You have like monitor their vitals. You have to give them like, you know, that ABCDE thing. You have to do their ECG. It's very important. You put ECG at the top. Yani if this patient came with chest pain, even if it's not typical, you still just do an ECG because it's very fast, yani. And this patient is a smoker, COPD, yani he's an old man, okay. Um, and then part of the management is whether you're going to send this patient home or whether you're going to observe them or are you going to admit them. So this is an important part of management. Um, and then so obviously after you admit them, you do VTE prophylaxis for them. Any patient that gets admitted, you have to do VTE prophylaxis, because usually patients in the hospital, they're mostly like lying in bed, and so because of that immobility, clots can form in the legs and stuff like that, or in random places, and then that can lead to even worse issues. And so always whenever a patient is going to be admitted, you're like, okay, are we going to give them like anticoagulants like enoxaparin and things like that, or are we going to give like those compression boots or whatever, which basically compress the legs intermittently and make sure that like blood is moving through the legs and stuff like that, okay. um and then so he was discharged. He was given voriconazole for a good while, okay, and then also broad spectrum antibiotics. um so discharged with oral voriconazole for 4 weeks. So in total, it would have been 6 weeks because he was given IV voriconazole for 2 weeks in the hospital, okay? COPD, maintain oxygen. Saturation should be between 88 and 92%. Bronchodilators were given. For the diabetes, we have to optimize his insulin regimen. We have to do medication reconciliation, so like the clinical pharmacist and stuff, and we have to send them to podiatry, retina clinic, and like nephrology. And we should do a follow-up pulmonary function test. And yes, that is the end of the presentation. Questions they asked me about the physical exam. So they're like, oh, in what case do you have, like, what are bronchial breath sounds? What do you normally have? Like vesicular breath sounds, right? Like normally in the lungs you have vesicular breath sounds, but because there's like a consolidation, there's like a dense kind of um yani look thingy, it's louder. Okay, that's why you have bronchial breath sounds. Like they asked me something like that, and then they were like, oh, so conjunctival pallor, what was his hemoglobin? So I should have mentioned the hemoglobin over here, but he did have anemia. He had like his hemoglobin was like 10 or something, and the doctor was like, oh, that's pretty low. And so and then she was like, normally, what should like a smoker, what should their hemoglobin be like? And I was like, it should be polycythemia actually, because of the chronic hypoxia or like hypoxemia. Any chronically, you don't have a lot of oxygen in your blood, and so that's why your body kind of programs itself to increase the number of like red blood cells you have and like the amount of hemoglobin you have. And so that's why in like long-term smokers, you see polycythemia. And so you would see like the plethora in their face, you'd see like palmar erythema and stuff like that. So yeah, that's the questions that I remember them asking me. Um, but yeah, that's it. Thank you. And if you have any questions, or if there's any videos that you want me to like make, just put them in the comments, please. Okay, bye.